Hi, good morning, everybody. Today we'll talk about screening and early detection and prevention of cervical cancer. And by the end of this week, we will vote for opinions regarding the presentations, whether we have it as one topic, as a lengthy topic about, let's say, cervical cancer screening and prevention, or if we have it in multiple sessions, like in a weekly basis. I'm gonna ask everybody to vote and then we'll take the majority. So let's talk about screening and prevention of cervical cancer. We are talking about screening as a pap smear and a prevention as the vaccine. So let's start from the basics and spend a few minutes on the screening term, or the term of screening. It's a test where you do it in a patient who's completely asymptomatic, meaning once the patient has any symptoms, your test is not a screening anymore, and it's called diagnostic test. An example of that, the glucose challenge test, mammography, as well as when you do a pap smear. So screening is a test you do with an asymptomatic patient who's at risk of a certain disease, and we try to have the highest sensitivity and the highest specificity in the same test. Sensitivity, it means the positive test among the positives, meaning the affected people, and specificity is the negative test among the negatives, meaning people who do not have the disease. To reinforce the point which we just mentioned, that the patient who comes with symptom, like let's say post-coital bleeding, and you're doing a pap smear, this is not screening anymore, this is diagnostic. A patient who comes with menorrhagia and you're doing an endometrial biopsy, this is not a screening anymore, this is diagnostic test. A patient who comes with a breast lump and you're doing a mammogram, this is not a screening anymore. You're doing a screening test to detect a group of patients who may or may not have the disease, and then you refer them to do a confirmatory test like a GTT to confirm the gestational diabetes after an abnormal glucose challenge test. You refer the patient for colposcopic assessment and biopsies. For a patient with abnormal pap smear, you refer the patient for a breast biopsy for a patient with a breast lump. This is to confirm the disease. To screen for a disease, it should be a health problem issue. I mean, you don't screen for a very, very rare disease. You should have a disease where there is a pre-symptomatic latent stage. As we know that in cervical cancer, we have a precancerous changes, which may take up to 10 years. And it should be cost effective, high sensitivity, and high specificity. And it should be acceptable to the population, and it shouldn't be invasive, so the patient will accept it. That cervical cancer is a preventable disease, and we'll have another lecture on cervical cancer. However, prevention and early detection of cervical cancer is possible. Possible because there is the vaccination where we have primary prevention, and we have the what you call it secondary prevention by doing screening pap smear to detect and treat precancerous changes. And then unfortunately, if you fail the primary and secondary prevention, you will treat a cancer where hopefully you can catch it or treat it or diagnose it in an early stages. It's about the vaccine, a preventable vaccine. We have two types of vaccines. We have the bivalent and the quadrivalent vaccine, and now we have the Gardasil 9. So the bivalent vaccine will protect against the oncogenic strains 16 and 18. The quadrivalent will prevent against the oncogenic and non-oncogenic 16, as well as 18 the oncogenic, and 6 and 11 the non-oncogenic. And we have the new vaccine Gardasil 9 which will prevent against 9 strains of the HPV causing or affected humans. We know that it's a very effective vaccine, very safe, minimal toxicities or side effect, and the only contraindication up to now to give the vaccine to a patient who's pregnant, but you can give it during lactation, even immunocompromised patients or a patient who are on steroids or HIV. One questions about the vaccine at the age of which you give it, usually 9 to 26. You can give it up to 45. We know that 9 to 26, it can provide 100% immunogenicity. However, there is an extended age where we can give it up to the age of 45 with a similar efficacy. Patients who are already sexually active, you can give it still, and that will prevent hopefully the high risk HPVs. A vaccine, you can give it to a patient who already exposed to HPV, because now there is a high likelihood of cure by the patient for that virus, so there is a clearance, so hopefully it will prevent reinfection. And we know that the patient may grab only one of the HPV strains, so the vaccine will prevent against the others. Other questions about it, as I said before, it's very safe, there is no serious side effects. Do we need to continue the screening? Yes, the answer. This is very common question, because the vaccine will protect against certain strains, but we know that there are maybe 100 strains of HPV affecting humans, so we still need to continue the pap smears, because we know that the vaccine is not a replacement for the what do you call it, the pap smear screening. Is it recommended for boys? There are certain what do you call it, provinces in the States and in Canada, they're still giving the vaccine for boys, because boys are the vectors for the virus. And dosing regimen, we have the bivalent and quadrivalent. Just to remember it, it's easy. The quadrivalent or the Gardasil is like hepatitis 0, 2, and 6, while the other one, the Cervarix, it's a 0, 1, and 6. As we said before, pregnancy is the vaccine is very safe. There is no contraindication except the pregnancy. Sometimes we need to do pregnancy test prior to administration, and there is no need up to now for a booster. A very common question: if the patient received 1 or 2 doses and then she missed the third one, or there's a delay, still she needs to restart the course. Otherwise, she can just resume the remaining dose and continue the vaccine or the third or second dose, unless there was a delay for more than 1 year. So if there is a delay for more than 1 year, let's talk now about the pap smear as a screening test. We know that there are 2 types of pap smears. We have the organized screening test, and we have the what you call it, the opportunistic. Organized meaning a patient will receive a letter by the end of the year stating that you are due for a pap smear, which we don't have here at all. The opportunistic meaning a gynecologist or a family physician will wait till the patient comes for any other reason, meaning for contraceptives, antenatal, postnatal, comes for any symptoms, and then you do a pap smear, and that's why they call it opportunistic. We have 2 types of pap smear. We have the conventional and the liquid based. Conventional is the usual, where you have to use a spatula and you spread it on a slide and then you fix it. This is the older ways. Most of you, maybe the new generations, you cannot or you don't remember it. The liquid based, this is where you have the new technology, where it has a lots of advantages compared to the conventional. The most important advantage is it is more sensitive in detecting high grade squamous intraepithelial lesions. So as I said before, the advantages of the liquid-based cytology compared to the conventional, this is what's mentioned here. It's more sensitive, clear, you can do it during the period, and the most important is you can add HPV serology. We should know that pap smear sensitivity is only 50%, and the false positive is only 5%. Remember that 50% sensitivity and false positive is only 5%. The comparison, assuming that you are a cytologist, you can see this is a busy slide where you have a lot of what you call it, inflammatory cells. Cervical dysplasia depends mostly on the nucleus itself, and in the next slide we're going to talk about what does cervical dysplasia means. This is you don't see well the nuclear details, and just if you focus now comparing this slide to this one, you can see how clear, because we know that the term dysplasia means nuclear changes, especially increased nucleocytoplasmic ratio, presence of micronucleoli, as well as increased mitotic activities, hyperchromatidism, and sometimes you may have mitosis, increased mitosis within the same slide. This all, and what we worry about usually as a precancerous is dysplasia, as the patient will reach almost, if you don't treat the dysplasia, patient will be a cancer. Present hyper, what you call it, dysplasia, I mean, and the term dysplasia in the cervix is almost equivalent to hyperplasia of the endometrium. To start the screening, usually we start the screening after the age of 20. Different recommendations with different age group. However, it should be within 3 years of sexual life. We know that the likelihood of cervical cancer is very low before the age of 20, and usually need at least like 3 years after sexual life to start the screening. And as we said before, there are two types of screening. You can do just a pap smear, or you can do what we call it co-testing. Co-testing meaning you're going to do a pap smear and on the same time you do the serotyping of HPV. This is called co-testing. Keep in mind there is another term called reflex testing, which we're going to talk about it. That's in abnormal pap smear, but here we are talking about co-testing. You have to do the pap smear every 3 years for immunocompetent patients. For immunocompromised patients, you have to do it more frequent. If you are doing a co-testing, meaning serotyping with pap smear, you can space it up to 5 years. Age you have to discontinue. There is a disagreement between the recommendations. However, 65 to 75, provided that the patient had a normal pap smears in the past. Sometimes if you have an older patient who never had a pap smear, you may do it once or twice. Make sure that for 5 years, if she is okay, you can continue. However, a very common question or important question, do you need to do pap smears after hysterectomy? And the answer usually you should ask before you answer it, what was the indication for the hysterectomy? If the hysterectomy was done for a benign disease like PPH or endometriosis or myoma, you don't need to do it. But if the patient had the hysterectomy for any genital dysplasia or genital cancers, you need to continue lifelong at least once a year. HPV testing, you have to do it for a patients who are beyond the age of 30, because we know that most of the patients younger than 30, they do have transient HPV infection. So it's not cost effective and most likely it will be positive. However, beyond the age of 30, you can do it, and it's called co-testing, meaning you do it with a pap smear and you can space your screening every 5 years. Important slide, and everybody should know it. There should be a standard reporting system, because we know that the cervical cytology, we have ectocervix squamous abnormalities or endocervix adeno abnormalities or columnar. So if you are working in a hospital, you should receive one of these diagnoses. If you receive anything different, you have to call the cytologist and tell them we need to follow the Bethesda system. It should be either ASCAS or ASC-H or L-cell or high cell or squamous cell carcinomas for abnormalities coming from the squamous. Abnormalities coming from the glandular or endocervix or columnar, it should be atypical glandular cells not otherwise specified, or atypical glandular fever endocervix endometrial, or atypical glandular fever neoplasia or adenocarcinoma. Remember that the word AGAS is not used anymore. If you receive it in a pathology or cytology report, call the cytologist and tell them we need to follow the new Bethesda system. Next week, inshallah, we will talk about management of abnormal pap smear, and we'll talk briefly about the colposcopic assessment and what are the ideas of colposcopy and the principles we used in assessing the patient with abnormal pap smear.